Hello, I'd like to welcome everybody to our webinar this morning, Accreditation, Why Bother, with Trina Fortune, Deputy Chief Executive Officer of ISQua. I'm going to give Trina a very quick introduction, then I'll hand over to her and we'll take questions at the end, if that's all right. So firstly, a little bit about Trina. Her expertise is in the development of international healthcare standards and external evaluation systems, particularly in accreditation. She has advised a number of both developed and developing countries in accreditation and patient safety systems. She has held senior healthcare management positions in Ireland and internationally. Trina has taught in numerous master's programs specialising in healthcare quality and is currently an external advisor for the Royal College of Surgeons in Ireland's master's programme. Trina leads a number of ISQua's flagship programs, including events, accreditation and lower and middle income countries. At this point, I would like, hold on one moment, I would like to hand over to Trina for the rest of the presentation. Thank you.
So thank you very much, Jane. And just while I'm opening my presentation here, I'll just get that out of the way. Hopefully everybody can see that. Okay, so sorry for that. I was just opening my presentation. Thank you very much to Jane, and I'd like to introduce Jane Clare, who is our new education manager here in ISQua. Jane joined us last week, and we're very, very fortunate to have Jane. She has a lot of experience in curriculum development, especially in the disability sector. So I'm sure if you're doing the fellowship or you want to do the fellowship or you're just going to join us for webinars, you'll hear a lot more from Jane in the future. So what I'm going to talk about for the next 40 minutes or so, and I'll take questions at the end. I want to leave as much time at the end for questions as possible, is to look and see why do we still need accreditation or external evaluation or standards? How do we actually implement them? And there's a lot of systems out there. I'm not just going to talk about accreditation. I'll talk about the benefits, and obviously I'm going to talk about the improvements that we can make, because like any quality improvement system, there are always improvements that we can make. So here are some of the reasons why we still need external evaluation, and I think we're always going to need it. These are some clips that I took from the newspaper this year. A lot of them are around the Mid-Staffordshire inquiry in the UK. As most of you will know, there were 2 reports published by Robert Francis about the problems within the NHS system, and unfortunately these went undetected for a long time. But basically mid-staff could happen in any country in the world. It's not just the NHS that has problems. I'm from Ireland, and the health services in Ireland have a lot of problems at the moment as well. As you'll see, there's a headline there from Nigeria about children that were killed when a specific drug became infected. So we're all kind of in this together, and patient safety instances are unfortunately not going to go away. So what are we going to do about it? Well, there's a lot of things we can do, and I only have 40 minutes to talk today, so I'm not going to be able to talk about absolutely every one of them. But what I would say to you is, if you see anything else in the presentation today that you'd like either me or somebody else to cover in the future, please just email Jane about it. But when I look about solutions around patient safety, I like to put it into a little kind of matrix. And I think the way, well, I'm not saying I'm like Donna Beaton, but I try to think in structure, process and outcomes. So some of the things we need in structures is we definitely need a culture, a no-blame culture, where the patient is at the center of everything that we do. We invest in our teams that are multidisciplinary, interdisciplinary, and there has to be leadership. So there are some of the structural things that I think should be in place. Then we need processes to implement our tools, external evaluation such as accreditation, etc. And I'm going to talk about that later on in this presentation. And then we need measurement. We need to absolutely measure and prove through evaluation, through indicators, as much of what we do as possible. So tools, quality and patient safety tools, we have a number of them. There's the good old PDCA cycle, Plan, Do, Check, Act, still very, very relevant today and still works. I've already talked about Donna Beaton, structure, process, outcome. I use this a lot, especially when I'm developing standards, root cause analysis, fishbone, going on to full systems of total quality management, lean management, and Six Sigma. And then going on to more comprehensive structural tools such as checklists and external evaluation. And as you can see, the majority of these actually start from award level there, the PDCA, Donna Beaton cycle, working up to an organizational level, and then when you come to external evaluation, it's actually at a national level. So that's a gradual progression from ward to national level. So I can't do anything about patient safety unless I talk about checklists. And most of you will know that checklists actually started in the aviation industry. They're quite simple, and I think they're quite simple for anybody who knows what they're talking about. But they run through the whole course of the flight, obviously, before they start, after they start, before they taxi, after they taxi. And there's various different things to tick off to make sure they're turned on, they're turned off, etc. And it's both the pilot and the co-pilot that do these checklists throughout the flight. But the person who actually took checklists from the aviation to the healthcare industry and who's now become very famous about it is Atul Gawande. And we were very fortunate to have Atul speaking at our conference in Edinburgh this year. He truly is a remarkable man. He's a great speaker, but he actually had the vision to see that something that can be quite as complex as healthcare can actually respond to a simple thing like a checklist. And to me, if you try and keep things as simple as possible, they're probably going to have a greater degree of success in the long run. And Atul decided to look at patients on an intensive care unit. And he realized that each patient could have up to about 178 actions per day. And because there were so many actions, interreactions with all sorts of staff in the unit, it now meant that this patient had a possibility of 1 to 2% of errors in those 178. So you can imagine the amount of errors in an ICU unit is probably more than on a ward. So Atul Gawande then was invited to work together with the WHO, the World Health Organization, and they developed the surgical safety checklist, which I'm sure you all know has become synonymous with improvements throughout the world in both the developed and developing countries. One particular gentleman has looked at the surgical safety checklist and realized that from the time before you go to surgery to the time you're in recovery and back on the ward, there's actually 19 areas that could probably harm you. And Atul and the WHO then developed this surgical checklist that has worked out extremely well. One of the first studies to prove the success of this was Hines et al. In 2009. This article was published in the New England Journal of Medicine. It was a research that spanned 8 hospitals in 8 countries, and the clinical outcomes were actually phenomenal. Since the introduction of the Safe Surgery Saves Lives checklist, the rate of death due to surgery decreased from 1.5% to 0.8%. So that's like half of the deaths were decreased during this time, and the rate of complications, namely post-operative bleeding, infection, reduced from 11 to 7%. So that's an absolutely great result. Now I just have to go back there for a moment. Unfortunately, there was another study that was published the following year that was in the BMJ, and they did recognize that there was a number of barriers identified to checklists. And one of them was actually the hierarchy in the theatre room. I'm a nurse, I'm quite used to working in the theatre, and I remember that the surgeon was always the most important person in the theatre room. And whatever he said went. If he asked you to do anything, you absolutely had to do it. But it's actually about a team approach. And sometimes what's happening now is the nurses that ask the surgeons or somebody who's quite senior to stop and actually do the checklist, they're finding that there's a little bit of resistance from people who think that they may not need to do a checklist. And it's not just consultants, it's nurses, it's theatre sisters, it's everybody on the team absolutely has to do this checklist. So hopefully the resistance to change will lessen as we go along using this checklist. And it's also being used now for maternal and child health, especially in the developing countries. So this is probably one of the most famous pilots who used the checklist successfully. You may remember Chesley Sullenberger. He was a US pilot a couple of years ago, and he successfully landed a plane that had gone into technical difficulties. A bird actually flew into one of its engines and it started to lose power, and he successfully landed that plane in the Hudson River without absolutely any loss of life. And afterwards he was interviewed, and he put it down to the fact that he had used a checklist before he took off. He is an experienced pilot, and he had actually used a simulator in the past similar to his crash landing that day, and also the teamwork of his crew. It wasn't just down to him, it was down to a team of people on the day. So moving on now from checklists and to external evaluation programs, and I'm not just talking about accreditation. There's a number of external evaluation programs out there. Certification, licensure, inspection, and regulation. And the commonality to all of them is that they all use standards to some form or another, and they all use an evaluation system. Some of them are written into law, like licensure and regulation. They're mandated, and some people would say they're actually easier to implement. I would say that sometimes they're more difficult because you're telling somebody that they have to do something, rather than in accreditation where it's a voluntary system and you're working on the culture, changing the culture of the person, of the organization, which is probably going to take a little bit longer, but in the long term it's going to last a lot longer as well. So today, unfortunately, I'm not going to have the time to speak about certification, licensure, inspection, and regulation. I really only have the time to speak about accreditation. So as I said, all of those external evaluation systems use standards. They're the one thing that they have in common. And that's quite a complicated definition there of the standards. It's from the BS, which is the British Standards Organisation in the UK, and it's taken from a Standard for Standards, Principles of Standardization. It was published in 2011. And basically what they're saying is the standard is the norm. And it's the norm that's based on science and research evaluation. It's not the norm that Trina Fortune decides, it's the norm. It's the norm that's built on consensus by experts evaluating, researching, and using science to decide what the norm is. So I think this is quite interesting. This is actually the first standard that was ever written in healthcare. It's by one of the gentlemen that I kind of hold in high esteem, Ernest Goodman. He was a surgeon back in the beginning of the 1900s in the US. And the reason that I liked him is he actually said that patients should be given a choice. They shouldn't just be told what hospital or what doctor they should go to, but they needed to be given a choice. And as you may recall, that's still a challenge that we have today. But these were the 5 things that he thought should be in any hospital or clinic. There should be a well-organized medical staff. That member should be licensed and ethical. That the staff develop rules and regulations, policies, procedures and guidelines. Each patient have a comprehensive medical record, and again we're having challenges around that today. And that diagnostic and therapeutic facilities are under competent supervision. He realized even early on, 100 years ago, that laboratories and X-ray departments were places of high risk, places where patients could be put at risk. So there are a number of standards that we use today in healthcare. Some of them are written specifically with healthcare in mind, like accreditation and patient safety. And some of them, like ISO, the International Organization for Standardization, have numerous standards that everybody can use. They're not specifically written for healthcare alone. So I've tried to correlate the difference between what I think is a good ISO standard and a good accreditation standard. There are numerous ISO standards. The last time I looked, there were almost 20,000. You can get an ISO standard from anything for dispensing liquids in the pharmacy to deep sea diving to IT, technology, best services. They are brilliant for structure and processes, really good for if you want to write policies, procedures and guidelines. As I've already said, they're not healthcare specific. They're good for a departmental unit level. They're not so great when you go to a whole system, a whole organization, because they tend to do only one specific area. They are based on self-assessment, which is good. They're more of an audit than an external peer review, which we use in accreditation. And one good thing about them is they are published in numerous languages. Most of them are published in English, French and Spanish, and some of them are actually published in Chinese, Mandarin, etc. So that's the good things about them. The good things about accreditation standards to me is they're healthcare specific. They're written by people who are experienced in healthcare. They're not just written for healthcare, but they're written for other things that are important to a hospital, like governance, clinical and management governance, financial governance, patient safety, risk management, information management, etc. They're definitely good at an organizational level. So they can bring all of the ISO standards into a good structure where you can look at the organization as a whole. They're based on self-assessment. They're definitely based on evidence-based standards that have to be current. When we accredit anyone, we tell them that their standards should be revised, if not every 3 years, every 4 years. We use experts, we don't just use auditors. And the one good thing to me versus ISO and accreditation standards is we use continuous assessment. So we don't just do an audit for a week. We continually assess the organization throughout a 3 or 4 year cycle. So this is the definition that we use here in ISQua, and a number of people use it. And the things that are highlighted there are the areas that are important to me and a number of people who work in accreditation. Self-assessment is a really, really important part. It should really take you in accreditation 6 to 9 months. You get a set of standards, and if you take your time self-assessing against those standards, you'll come up with a really good quality improvement plan. If you then get a group of experts in to assess that plan, you'll get another phase to the plan, their recommendations of how to improve. It's obviously based on standards, and then, as I said in my last thing, it's about continuously improving. It's not just about the week of the accreditation survey. So what I say is accreditation is definitely a process. It's not a single event. And I've been lucky, I've surveyed all over the world in hospitals, and you will see some hospitals that just get the place painted for the week that you're going on. Everything is spick and span and everything looks lovely, and the policies and procedures are all written up to date, and all the staff know about the policies and procedures. But they think then that when you leave the organization that they can get lax and they don't need to continually implement those policies. But we'll come back. We started doing checks in the last couple of years of hospitals that are unannounced. JCI do this a lot, Accreditation Canada do it a lot. And I think it's really good for hospitals or clinics to know that this is a continuous quality improvement cycle. You're not going to get everything done and ready and 100% right for the week of the survey. So a little bit about the survey methodology itself. It's based on standards. The self-assessment should take between 6 and 9 months. We then use peer-reviewed surveyors, and most accreditation bodies throughout the world will use peers. These are experienced people. They're CEOs of hospitals, they're deputy directors of nursing, they're directors of nursing, they're consultants, people who have a lot of clinical and management experience. We then write a report for them with recommendations, and we set them on a continuous assessment journey that generally takes 3 or 4 years. And then if they're successful in all of those things, they'll get an accreditation award. And most people at a clinical level will give this award for 3 years, or some people nowadays have actually moved it to a 4-year award. So as I've said earlier, accreditation standards span across the whole organization. They look at all the core business models that you can see up there on the screen. And then they'll also look at the clinical services. So depending on the specialist areas that you cover, it could be cancer services, or it could be terminal services, or it could be pediatric services. They'll then look at specific services and standards around those clinical specific areas that you cover. Obviously, like any standards, they have to be current and based on current evidence, research and science. The whole scheme itself has to be based on self-assessment, peer review, and consistency in application is really important. So if you're setting up an accreditation scheme, you have to be sure that the way you assess Hospital A is exactly the same way as you assess Hospital B, Hospital C, etc. And the way that you award that hospital is the same across every single institution that you go into. So the benefits of accreditation. And accreditation has been going on for almost 100 years now. It started with Ernest Codman in America back in 1913. It has had its moments when it's been very, very successful and people wanted it a lot. It then had its moments when people thought that regulation, licensing, certification were probably a lot better. And really one of the difficulties of it over the years is that, and I'm one of the people to blame for this, we didn't do enough scientific research into the benefits of accreditation. Or when we did that research, we didn't do it using really robust scientific methods. So we're now 100 years on, and we've really only started to research accreditation properly in the last 10 years. People like David Greenfield, Jeffrey Braithwaite, etc., Charles Shaw, have done a great job, but we really, really do need to do a lot better. And the other thing about it is it's difficult to measure. So accreditation spans over a 3 or a 4 year period. And a lot of things can change in the hospital in that period. The CEO can come, a new CEO can be employed, a new director of nursing. The budget of the hospital can increase, or as has been evident in recent years, it can be slashed in half. So it's very difficult to say that it's accreditation alone that has actually caused the improvement in clinical care. But there are some studies, and one of the first is back in 2010 by Charles Shaw. It was a very small sample of European hospitals, roughly about 11, and he compared ISO standards versus accreditation standards. And you'll see there that the green bar are the people that used either that used accreditation standards. The yellow bar are the people that used ISO or certification standards, and the red ones are the hospitals that didn't use anything at all. And overall, there is an improvement in the people that use accreditation standards, a little bit more improved than ISO. And obviously people who didn't use anything at all weren't as good as people who used either ISO or accreditation. But the interesting thing to me is that the management overall was better in the accredited hospitals versus the ISO hospitals, and patient rights were actually better in the ISO hospitals. So ISO standards are a lot more customer focused than accreditation standards are. Clinical organization was equally as good in either accredited or ISO hospitals, and patient safety, interestingly enough, was a lot better in an accredited hospital. So moving on then to Australia, this is one of the first big research studies that David Greenfield and Jeffrey Braithwaite did back in 2008. And they said that accreditation did definitely promote change and professional development. And it may have an impact on the financial improvement, financial controls within an organization, and the quality performance. And it probably did increase the credibility of the hospital, but this would only be probable and possible with public disclosure, namely when the reports were published and put up online, and that there was insufficient evidence to know if accreditation actually improved the patient satisfaction within a hospital. So Canada then in 2011 did a large lit review, and within that lit review they listed 25 benefits of a hospital that was actually accredited, and I've listed only some of them there. They felt that an accredited hospital was better with a risk management system. They had better interdisciplinary teams. They were more effective teams, better communication, and definitely an accredited organization did promote measurement and the use of indicators. But obviously improvements were needed. And like Jeffrey Braithwaite et al., they felt that it didn't increase patient satisfaction. And the way that accreditation systems actually captured data was very, not inaccurate, but was very cumbersome. And these were some of the clinical benefits that they found in their lit review. Interestingly enough, all of these studies took place in America. They're all within JCI, or the Joint Commission accredited organizations. And they all have proved that clinical outcomes are slightly better in an accredited hospital. The first one is in a transplant unit. The second one is in the stroke unit, where they said that the mortality rates were better, but there was no change in readmission rates. And the third hospital there is an ambulatory care facility, where they said that they were less likely to be re-hospitalized following a colonoscopy procedure. So moving on again to Australia, and Maurice Hincliffe, who is a colleague of Braithwaite and Greenfield, he did a rather large review last year of 58,000 studies that he found in quality improvement. There were only 122 that were actually scientifically robust. So while we've got a little bit better, we really, really need to improve our scientific robustness around the way we research accreditation. He found that his study spanned 29 countries. The majority of the accreditation organizations had been formed after 2006 and were housed in either America or Australia. Interestingly enough, the least of them were housed in Europe. And lower middle income countries since 2006 have really started to become interested in accreditation. And 64% of these were in acute healthcare. The amount of organizations that are going into accreditation in primary care, aged care, etc. has started to increase, but not at the rate of our acute care colleagues. And the main findings that Rees found was that there was a 53% demonstrated greater performance in accredited versus non-accredited hospitals, and this was either in performance measures or outcomes measures. And from the organizational point of view, he said that 51% of them showed improvements in standards of infection control, policies, procedures and guidelines, promoted a culture of quality, greater leadership skills, and did improve patient safety. So things are improving, and we are doing better research, and we are beginning to show that there are benefits to accreditation, but we still need to improve certain areas around it. The way we collect our data, it is cumbersome. People are still saying it's a big paper exercise, the amount of policies, procedures, guidelines that we need to collect. As accreditation bodies are maturing, they're moving away from collecting the policies, procedures and guidelines around the process areas, and they're moving to being a lot more slicker, collecting data, outcomes measures, outputs, key performance indicators, etc. We need more and better research, as I've said, especially in the non-acute care sector. We definitely need to reduce the workload associated with accreditation and the burden of excessive audits. About 8 years ago, I did a study in Ireland of all of the people that go into one of our major academic teaching hospitals here, St. James's in Dublin. And there were 43 people that went in doing specific audits, whether it be nursing audits, medical audits, laboratory audits, food hygiene, etc. And then because we were affiliated with Trinity at the time, when you put academia on top of that, it actually rose to over 80 audits in the 3-year time frame. That's just too many audits. And accreditation can actually help to bring all of those together into a really slick, structured process. We definitely need to improve how we use our patients, our service users, our clients in our accreditation process, from developing standards right through to our surveys, how we develop policy, procedures, etc. And we need to get more senior medics involved. Some of them are still very, very skeptical about accreditation, but the more research we do and the more science that we can show them, the more results that are written in such a way that they're used to looking at key performance indicators, improvement in patient safety, etc. I think the more and more of them will come on board. We need to start teaching the public an awful lot more about what accreditation is, and the only way we can do this is by being more transparent and publishing our reports, putting them up on our internet. So some people aren't ready for accreditation standards, which are actually the gold standards. They're quite hard to achieve, especially in developing countries. And EMRO is a project I was involved in. EMRO is the Eastern Mediterranean Regional Office of the WHO back in 2008. And these were some of the developing countries like Cairo, Tunisia, etc. And the WHO wants to develop standards for them that took into context that they didn't have a huge amount of data and they didn't have a lot of resources in these countries. So they wanted us to write more standards that were based on minimal data rather than accreditation data. We wrote these around the core standards as you would in any accreditation scheme: leadership management, patient involvement, safe clinical practices, safe environment, which is a big thing in developing countries, such as clean water, etc. And then lifelong learning, which was professional development. And we wrote them in a structured way so that the safety element was the core element that they had to achieve, and then we gave them a developmental part. So once they achieved the core part, they could then stretch themselves to go on and do even better, which was actually mirroring an accreditation scheme. So that's just one sample of that there. It has worked extremely well. We started with 7 countries. They have done the first round of evaluations and they're now going on to a second round of hospitals in the area. So everyone wants to know, does quality actually save money? And it's a bit like the research that goes into accreditation. We don't really know because we haven't been really good about doing proper scientific research. A lot of us that research reducing costs in quality improvement projects are nurses, doctors, etc., that don't have an awful lot of experience in accounting. I would say if you're doing a big quality improvement project that spans the whole hospital, get somebody who's actually experienced in accountancy to do up your spreadsheets, etc., to actually do a cost analysis before you do the quality project and then another one post. What John Overwright is actually saying is maybe it does. You think that it does because if you do something right the first time, every time, it would reduce the amount of times that you do it, and it should actually cost less. But unfortunately, the evidence isn't there to prove it. John Overwright is a quality guru from Sweden who's done a lot of evidence into the cost of quality. And this is something he did with the Health Foundation in 2009. He looked at all of the data that there was out there around quality improvement. And you'll see there the inverse pyramid. The bottom, or the top of it as it is in my structure here, the majority of the published articles are around adverse events, risk management, patient safety. And you can see the yellow bit there represents the amount that actually looked at the cost reduction of those, which is less than 1% of all of the articles. The second biggest amount of articles were on clinical guidelines, and again, really little evidence of cost implications in any of those articles. The third amount of data was on quality improvement tools, and substantially less in them. It was only about 0.5%. And then if you look at all of the articles together and the overall savings from quality improvement, less than 1% of the articles actually looked at financial implications. So in this day and age of economic hardship, which spans the entire world. We really do need to get a lot better in how we present our facts and how we look at our financial and cost implications of our quality improvement projects. So I'm going to start wrapping up now with this gentleman, Ernest Codman, whom I said was one of my favorite people back over 100 years ago. He thought that 3 years from the time he wrote his first standard that people were going to think him really, really eccentric, especially the public, because he was going to say that they must find out what their results are. They must analyze their results to find their strong and weak points. They must compare their results with those of other hospitals, and everybody must welcome publicity, transparency, not only of their successes, but for their errors as well. So not be afraid to actually admit that we do make mistakes and to learn from those mistakes. So he said this back in 1917, and he thought within a few years from then, maybe 1920 or whatever, that most of his opinions would not be eccentric. But I think you'll probably all agree with me that we're still striving for these cultural changes today. We still want to blame people for making mistakes, and unfortunately that's not the best way. We need to open up to a no-blame society. We need to start measuring everything that we do, and we absolutely need to do scientific research much more robustly than we have in the past. So to conclude, I've tried to cover an awful lot there in the last 45 minutes. One of the main things is that we do need to try and assure that patients are safe in our care. And it's always going to be a challenge. We're never ever going to have a hospital that's totally safe. But we really do need to try and mitigate against risk. There are many tools that we can use. I've only touched on some of them today. Checklists are very, very good. PDCA cycles, structure, process, outcome that Donna Beeden first used. But they're all only singular tools, and there are too many audits, too many measurements in our hospitals today. But accreditation is one thing that can help to bring them all together. But we also need cultural changes. We need our leaders to grasp accreditation, to grasp quality improvements, to grasp the importance of multidisciplinary team working and putting the patient at the center of everything that we do. Research is improving, but we all need to do research. No matter how small it is, we need to do it as scientifically robust as is possible, and we need to look to see, to measure what the cost implications are of not only our research, but the tools that we're using. And finally, we need to reduce the burden of excessive audits and resources required to participate in any scheme. Remember, accreditation is voluntary. I hope it will always stay as voluntary. Accreditation uses gold standards. There are standards to strive for. It's a journey. It's not just 1 week out of a 4-year period. It's absolutely a journey. And I think if we try and keep the patient at the center of everything that we do, remember that unfortunately we are going to make mistakes, but learn from those mistakes, measure our risks, and put some kind of structures in place. We will eventually have hospitals, primary care clinics, accreditation schemes that do improve care for patients, that make sure that hospitals aren't a place of harm for our dearest to go to, our patients, our vulnerable colleagues in society today. So at that, I'll finish and I'll thank you all for listening for the last 45 minutes and hand you back over to Jane while I take a much welcome short glass of water here. So thank you, Jane. Hello. I'm afraid we're having some difficulty at the moment with Jane, who's going to lead the questions, so I'm just waiting to have the questions sent over to me. And I'd be happy to answer any that I receive. Okay, so apologies, folks. The first question I have here is, not everybody can afford accreditation, so what else can we do? So that's a really good question. Not everybody can afford accreditation. Some schemes can be expensive, and especially in developing or even developed countries, we don't have a lot of extra money these days. So what I would say to you is the self-assessment part of accreditation is actually one of the most important parts. If you can borrow a set of standards from anyone, most accreditation bodies actually have them up online, free to download. Actually do the self-assessment yourself, either from the hospital level or from a ward level. Take the self-assessment, take the questions that you're asked, and systematically go through all of those questions and be honest with yourself. That's the most important part. Be honest, identify the areas that you do really well, and remember there are things that you do really well. And then the standards themselves will bring up things that you need to improve on, and then go out and see what other people have done to address those improvements. Because remember, anything that you found in your hospital, in your clinic that you need to improve on, somebody else has probably had exactly the same problem, and they'd be only too happy to share their improvement philosophy with you. So do the self-assessment process. You'll get a quality improvement report out of that, and slowly prioritize the things you need to do first and work on those. And then maybe you'll get some money eventually to get a group of peers to come in and actually help you with that report, that quality improvement. So I think I have another question here. Do we have any data on the impact of accreditation for healthcare facilities in developing countries, especially Africa, since all the data is in the developed countries? Really good question, and I have to say I don't know of any published data at the moment in Africa, but there is a group that have started in the last year. We've actually accredited their standards called SafeCare. They're a group of 3 organizations that have come together, JCI, COSASA, and Safecare themselves, which are based in Holland. And they actually now have their own standards that are developed specifically for countries in Africa. And I do know that they have started to collect data. They presented at our conference in Geneva last year. And if I have the name of that person who sent in the question, I can look up that presentation and I can send it to you. So I think it's Ilui Ilomachi. Apologies, Ilomachi, for the way I've pronounced your name, but I'll have your email address, and I'd be happy to send on that data to you. So the third question I have here is, do we need to emphasize self-assessment or improvement plans? Again, it's a good question. And I think what we need to emphasize is the improvement plans. The self-assessment itself is only a ways to a means. So the self-assessment is only the way you're going to come about your improvement plan. What I'd say to you is, when you're doing your self-assessment, don't do it on your own. Get a group of people together, multidisciplinary. Everybody, you know, a pharmacist, a nurse, a doctor, a porter, a cleaner, everyone is important in an accreditation self-assessment team, because everybody has something to add. And then when you identify what your improvement plans are, you already have that team in place that can help you implement the policies, the structures, the outcomes, whatever it is that's going to help you get rid of that recommendation. But remember, you're probably not going to mitigate completely against the risk or the improvement that you've identified. So you need to continually assess it. So even after you do the first self-assessment, put the improvement in place. You have your multidisciplinary team together. Maybe leave it for 3 or 6 months and then evaluate it again, and you'll see that it's even improved even more. And then you can go to the next step and maybe look to see how you can improve it even more. And then the thing to do is, looking back to my last question, is actually publish that data, especially if you're in a country who's only starting out on a quality improvement journey. This is one area that I definitely didn't do well. I started in accreditation about 12 years ago. I started with Roisin Boland, who had started the Irish Healthcare Accreditation Scheme. Herself and John Sweeney had actually started up that scheme. And we did start to measure at the very beginning what things were like in the hospitals before we implemented our accreditation scheme, but we probably didn't measure enough. So what I would say to you is, remember to measure before, measure during, and measure after you've implemented. And don't be afraid to be transparent with your results. Put those results up online. Learn from each other and take improvement plans from each other as well, because as I said before, there's always going to be somebody who's been in that place before. So I hope I've managed to answer some of your questions, and thank you for everybody for listening to me. What's now 55 minutes. It's not easy to listen to me all the time. Hopefully I actually haven't spoken too quickly, but if there's anything you've missed at all, please just send in your questions via email to Jane, and she'll make sure to send them on to me. And as I said at the beginning, if there's any other area that I've touched on today, regulation, patient safety tools, checklists, etc. Checklist certainly isn't my forte, but regulation, etc. is. I'll either do another webinar myself, or we'll ask Jane to source another one of the ISQua experts to do something in another topic. So again, thank you very much for listening, and at that I'll close off on today's webinar. Bye-bye.